Well, here we go. Cardiac emergencies. The very first thing we're going to talk about is the electrical conduction system of the heart. Because much like when you hit the light switch in your house, without electricity, absolutely nothing is going to happen. We made our peace yesterday with the fact that the heart functions as a pump. I think we got a pretty good handle on that. The heart does function as a pump. It is a muscle, and this pump is run by electricity. The heart has its own electrical current that passes from the pacemaker cell, or the SA node, the sinoatrial node in the heart, that starts that electrical current passing through all of these neural pathways down to the apex, or the bottom of the heart, where the electricity is actually conducted into these myocardial cells, into the muscle cells and tissues of the heart, to stimulate a contraction and stimulate a beat. The heart actually beats from the bottom up. The ventricles contract, squeeze blood out, and it all starts way up high in the sinoatrial node. From there, that electrical current passes into the atrioventricular node, and the atrioventricular node conducts all of that electricity down a bit further through the bundle branches, and we get to these little things at the bottom, these tiny little nerve fibers at the bottom of the heart that wrap around the heart from the apex up like fingers. Those fingers are called Purkinje fibers. And Purkinje fibers is where this electrical current gets to a dead end. There's no more electrical current, or electrical wiring anyway, once we get to the end of those Purkinje fibers. And that is how the electricity is introduced into the cells of the heart. And that is how the actual beating of your heart is stimulated, anywhere from 60 to hopefully 100 times a minute, all day, every day, since the day you were born until the day they shovel dirt. That is how every single heartbeat works. Next on our list of things that we need to get through is following a drop of blood through the heart. So we have the superior vena cava and the inferior vena cava marked in blue on what would be our left-hand side, which is, just to make things even more confusing, our left-hand side of the picture. When we speak anatomically, what side of the patient is that?
The right side.
Yeah, it's the right side of the heart. Everything's opposite when we're looking at somebody standing in the anatomical position. We have the top chamber on the right side of our patient here. That's called the right atria. The right atria receives blood back from the body through the superior vena cava, which brings blood back from the more superior portions of our patient, so up high. And we have the inferior vena cava, which brings blood back to the right atrium from the inferior or lower portions of our patient. And it's all returning to the right side of the heart after it has dropped off its oxygen, caused that cell to create energy, and brings back carbon dioxide. The atria of the heart don't really have a whole bunch to do with the actual beating and forcing out of blood. The atria, think of them as storage chambers. They hold on to blood until the ventricles are ready for more blood to be filled into them. So the right atria stores that blood that's returning from the body. When the heart contracts, the right ventricle will empty and squirt blood out to the lungs. The tricuspid valve will be closed at that point, so that blood doesn't regurgitate back up into the atria. When the heart goes into systole or relaxes, that tricuspid valve will open. Blood will empty from that right atria into the right ventricle. And the next time that electrical impulse stimulates the heart to beat, ventricles contract, and that deoxygenated blood will pass through the pulmonary artery and go in, the pulmonary valve into the pulmonary artery, because arteries travel away from the heart. They're not named for what they carry, they're named for which direction they go. The pulmonary arteries carry that deoxygenated blood out to the lungs to go to that pulmonary, capillary bed that surrounds those alveoli so our gas exchange can take place. This is deoxygenated blood. It's high in carbon dioxide. The oxygen moves out of the alveoli. The carbon dioxide moves out of the blood. Those gases pass by one another on their way to now oxygenate our blood. The now oxygenated blood, or oxyhemoglobin, passes through the pulmonary veins because veins return blood to the heart, and we wind up in the left ventricle, the left atria. The left atria stores that blood until the next time the heart beats. The heart beats and then gets ready to refill. When the ventricles refill, the blood leaves the left atria, passes through the bicuspid valve, fills that ventricle back up. Another electrical impulse is conducted from the SA node through the AV node, down through the bundle branches, down to those Purkinje fibers. The heart squeezes from the bottom up, and blood is ejected from the left ventricle, out through the aortic valve, into the aorta, and off into systemic circulation, simply just to go and provide that oxygenated blood flow and perfuse all of our cells and all of our tissues. And that is every drop of blood in your person with every single heartbeat. This is the way that it works. Right atria, deoxygenated. Right ventricle, deoxygenated. That right ventricle squeezes. We go from through the pulmonary arteries down to those pulmonary alveolar capillary beds. We have gas exchange happen. Pulmonary veins return that now oxygenated blood to the left atria. The blood empties down into the left ventricle, fills it up, and when the left ventricle squeezes, we go through the aorta with that oxygenated blood out into systemic circulation, down to the cellular level. Gas exchange happens again. The blood is oxygen rich, the cell is oxygen poor, and that is perfusion 101. That is the way that this whole system works. So there's our pump function of the heart. There's the way the electricity works. There's the way that the actual beating and travel of every single speck of blood in your person is going to work through your entire life. Now we talk about the pipes a little bit. What did we learn yesterday about our piping system in our person?
Waiting for something.
That it controls everything?
So yeah, it's gonna control perfusion to a certain degree anyhow, because if these pipes aren't doing what they're supposed to, if they're either open or too big or something else is wrong with them, all of that oxygenated blood flow is not going to be able to go where it needs to go. Now, if we look at the map of all the arteries and arterioles and veins and venules throughout this entire person, I'm not going to ask you to name all of these. I couldn't name all of these. We need to be able to identify some important ones. We need to be able to identify places where we're maybe going to, check a pulse. So carotid arteries, brachial arteries, radial arteries, femoral arteries. And anywhere there is a large artery or any artery at all, there is a vein that coincides with it. Why?
Because it has to, the arteries go away and the veins go too.
Absolutely. The arteries are carrying stuff away and the veins got to bring it back. So anywhere we have oxygenated blood flow, we have to have an artery, we have to have a vein, because that's how the supply gets to and from. So just keep that in mind. Know the major ones, know the big ticket ones. We're going to talk about the aorta more. We're going to talk about the superior and inferior vena cava more. Those aren't exactly pulse points. We're not going to be, digging around in somebody's abdomen or chest trying to feel a pulse on their aorta. But some of the big ones, carotid, radial, brachial, femoral, those are places we need to be able to identify. Those are things that we need to know where they are and sort of what we're looking at. How do you guys think the heart perfuses its own tissues? I mean, its job is to move around oxygenated blood. How do you think that the heart muscle cells actually get that oxygenated blood flow to use?
By contracting,
All
when it
right,
contracts itself.
it contracts, it sends that blood out, and then right off the top of the aorta, we have these coronary arteries. Now, I'm sure you've all heard of coronary artery disease before, right? It's a product of too many double
Yeah.
cheeseburgers and thinking you're Superman and gonna live forever.
Plaque builds
Um,
up in your arteries.
yeah, it's when stuff builds up in there, right? We have all this cholesterol and all this plaque building up in those arteries. And these coronary arteries, traveling, remember, away from the heart, are carrying oxygenated blood from that left ventricle down through this network of arteries and arterioles, which are just small, tiny, little bitty arteries, until we get down to that cellular capillary bed of all the cells of the heart. And when we have a blockage in one of these coronary arteries, so think a blood clot, and we'll explain the process of this here, of all of that in just a minute. But if we get a clot or some form of blockage in one of these arteries, that's when our patient winds up with a myocardial infarction. That is what the cause
Mhm.
of a heart attack is. The way this all works with heart attacks and blockages and coronary artery disease is we have that buildup of plaque on the wall of these coronary arteries. And that buildup of plaque actually will make the internal diameter, so the space on the inside of this right or left coronary artery, smaller. And soon enough, it shrinks and it shrinks and it shrinks until the point where blood doesn't get by anymore for one reason or another. And when that blood starts to pile up and we get some turbulent blood flow, the body reads that turbulent blood flow as there's a break somewhere, there's a cut. So we need to send platelets. And all sorts of platelets come to this coronary artery that's already little, and a blood clot starts to form. And when we have a blood clot, let's see, this is probably the easiest place to do it. Say we had a blood clot right here in this coronary artery, and it blocked off that right coronary artery completely. We could draw a circle right here around all this tissue that's not getting any oxygenated blood flow. And what's it going to do if it stops getting oxygenated blood flow?
It's gonna back up. It's gonna like it'll be backing up and like sort of like a hose when you tie off the end of a hose, it builds up.
So pressure is
No,
going to build up. I won't dispute that with you. But what's happening to all this tissue that's not getting any blood?
it's dying. It's not getting any oxygen.
It is absolutely dying and it's not getting any oxygen. And you know what happens then? Your patient
Then
might complain of some chest pain. Your patient might tell you things that make you think you need to give them aspirin or nitroglycerin. And we'll talk about the mechanisms for both of those at length here in just a little bit. But if all of that tissue dies, tell me this, is it going to come back?
no, that doesn't regenerate.
Yeah, it's dead forever. And guess what it interferes with?
You're pumping
The
your
heart's
country.
ability to function as a pump. You're spot on. So a significant myocardial infarction interferes with the heart's ability to pump blood around appropriately and can lead to some of the stuff we talked about yesterday. Cardiogenic shock, lack of ability to get blood out and maintain pressure, and hypoperfusion. And some of the signs and symptoms that we talked about yesterday with shock, we may actually see in a patient who's having a significant cardiac event just based off the fact that all of that tissue is at first becoming ischemic. Ischemia just means it's getting grumpy from lack of oxygenated blood flow. It doesn't mean there's none. It doesn't mean the tissue's dead yet. it means that it's not getting enough and it's kind of getting irritable about it. Still going to produce some chest pain, still going to show us almost all the same things. It's not really our job to split that hair between, is this a myocardial infarction or is this myocardial ischemia in the field? We get the ground rules and the protocol of, does my patient have acute coronary syndrome? Is my patient suffering from chest pain indicative of a cardiac event? Because chest pain from getting whopped in the chest with a golf club or a line drive at a baseball field is going to be a lot different than chest pain from your patient who, like the gentleman we saw in chapter 14 yesterday, is just standing there clutching at his chest, looking uncomfortable. And they're going to tell us some things when we get into our assessment, and our vital signs are going to show us some other stuff in our assessment. And we're going to come to the idea that this patient, for one reason or another, is having a problem with their cardiac system, and that problem is something that I can treat as a BLS provider. I don't need any fancy equipment other than a blood pressure cuff. I don't need to really do anything other than talk to my patient and do a good assessment so that I can get down to brass tacks and figure out, did this patient have a traumatic event? Did this patient spend all weekend out gardening and now their chest is just kind of sore? Or was this patient sitting on his couch minding his own business, and then bam, all of a sudden chest pain, and he feels like there's an elephant sitting on his chest, or somebody put a ton of bricks on his chest? And those are telling me two completely different things. So our money is earned here with our chest pain patient by making sure we hit all of our points on our assessment, and not necessarily being able to fully quote diagnose what's wrong with them, because the only way they truly diagnose a heart attack is with lab work. Even a fancy $25,000 EKG machine that we have on every paramedic truck here in Cataldo doesn't diagnose a heart attack. It tells us that it's likely my patient is having a heart attack, but until we get some blood drawn and get them to the emergency room, it's not truly a heart attack. We just need to be able to identify the most likely causes of what's going on with this patient.
The signs and symptoms.
Absolutely. And your protocol. The better we know our protocols and the better we know our hallmark signs and symptoms, the easier some of this stuff is going to come. I see a hand raised. Did somebody have a question?
Sorry, I got a question for you.
All right, shoot.
What were you saying? I completely missed it when you were saying describing how cardiac arrest happens. I got up. Let me see. It's like a buildup of plaque in the right or left coronary arteries. Eventually becomes a blockage, so the body sends a bunch of platelets. But I forget. I was trying to take notes on why it sends platelets.
Oh, sure. And that comes up again, but I'm going to answer you now since you asked.
Okay.
What happens is when that artery narrows, right? That coronary artery gets smaller and smaller and smaller. It soon enough causes turbulent blood flow through that artery. The body interprets that turbulent blood flow as we have a leak. And when the body senses that they have a leak, they start this whole clotting cascade to try and make that leak stop. And in doing so, we form a clot in that coronary artery that didn't have a leak to begin with, that was already narrow and too small, and we get a blockage. And that coronary artery is completely and totally closed. And that is the beginning point of our myocardial ischemia and our patient complaining of chest pain. And without oxygenated blood flow being restored, that ischemia turns into infarction, which is your true heart attack, myocardial heart muscle infarction, death of. So it progresses from, narrowing to clot formation to ischemia, and then from ischemia to infarction, unless it's corrected.
Okay, Got it. Thank you.
No problem. So we've gone through a lot of this when we talked shock and when we did the human body. We're going to talk about some of these cells here at length. Tell me, the red blood cells, what on earth is their job?
Don't they
Move.
fight? Oh no, move.
Yeah, they move stuff. Absolutely. They carry oxygen and carbon dioxide and nutrients and all that stuff back and forth throughout the body to make sure that perfusion is actually happening. Now, Jessica, you were talking about fighting. That's the next on the list. Our white blood cells.
The white ones. Yes.
They are pretty much the defense line for the body. They go out, they identify things as either self or not self. Self is the cells and tissues and little bits that they leave alone. If they identify something as an invader and not self, off they go, they call in all their friends, and their mission in life is to kill whatever that not self thing is.
So basically, they're like a gang.
Yeah, they're pretty much like a gang. And when we talk immunology, either later on today or tomorrow, we're going to talk about how sometimes when that gang shows up, the body is not doing itself any favors. Most of the time, these white blood cells go on about their business, do their job every single day, day in, day out, cause us no problems at all. When we talk anaphylaxis and anaphylactic shock, the main cause of that entire problem is these white blood cells identifying something and freaking the hell out and nearly killing our patient, or actually killing our patient, depending. What we're going to talk most about today is these platelets. Platelets are the pretty much cause of all of the problems we're going to talk about with acute coronary syndrome, myocardial infarction, any of the fancy $10 words, because in this situation here, the platelets are the troublemakers. You know, they're just going on about their business, doing what the body's telling them to, doing what realistically their function is and what they're supposed to, but they are what's causing all the problems. The way your body forms a clot or a thrombus is by aggregation of all these platelets. Aggregation, again, just another fancy $10 word for recruitment. So those platelets sense that something is wrong and they go to that area and they stick to something because their job is to be sticky. And then the more they stick, the more platelets come to that area. The more platelets come to that area, they start sticking together. And further on through this clotting cascade, thrombin and fibrin are now making that clot next to bulletproof. It is practically impregnable. Once a blood clot forms and sticks and gets stuck in place, as long as it's stuck on there good, these fibrin fibers mesh throughout all of the tissue and throughout all of the area to stick more clots. So we have the initial problem of that plaque building up. Plaque builds up when the internal lining of our coronary artery gets damaged, and then it streaks and it leaves these messy little spots that cause that turbulent blood flow. And then as our patient's coronary artery disease progresses, you can see how much smaller the internal diameter of this artery is. You know, here we have plenty of room, but we have that pesky little streak of fat that's building up in the endothelium, the internal lining of that artery. And the more fat that winds up stuck to the inside of that artery, the more damaged the tissue becomes and the smaller everything gets, so less blood is passing through. And then more fat and more cholesterol and more junk piled up on the wall of that artery until eventually something breaks loose and that turbulent blood flow is caused. And the minute that happens, these platelets start showing up and they start getting sticky and they start mushing themselves together, and then we have all of that fibrin, and we have that clot now just becoming bulletproof and closing off that artery altogether, until sooner than later, there's no more space for blood to get through. And if no blood is getting through there, that heart tissue on the other end of that artery is no longer getting perfused, and we wind up right back at our picture of the heart with a blockage in one of the coronary arteries, causing myocardial ischemia, which is just, like I said, general crankiness from not getting enough oxygen. And that myocardial ischemia, if it's not corrected, soon enough turns into myocardial infarction, and then that heart tissue eventually is going to die. And once it dies, it will no longer beat, it will no longer be a piece that functions as a pump. And if it's not functioning as a pump, my patient is going to have a decrease in their cardiac output, a decrease in the amount of blood that the heart is actually able to squeeze out with every single beat. And that's going to cause a lot of the down the road problems that we see with patients after they've had a heart attack, because the heart's pumping ability has been impacted when our patient has a myocardial infarction. Now, that's not to say that every single time a patient has a heart attack, they're going to die. That's not the way that this works. Because with our treatments and treatments that can be offered in the hospital, they can get rid of those clots, they can open these arteries back up, all sorts of good things can happen for this patient, and they can actually restore perfusion. They may actually catch it in enough time that if they restore perfusion, that piece of heart muscle doesn't actually infarct, it's still just ischemic. So what does that mean? If it's still just myocardial ischemia, not true myocardial infarction, what's going to happen when they restore that oxygenated blood flow?
Will it come back? The
Yeah,
pumping?
if it's only ischemic and not dead, it may actually start pumping again. It may actually start conducting some of that electrical impulse that's being stimulated into it, and it may actually continue to beat. That's why when we talk about heart attacks and we talk about acute coronary syndrome and treating our patient and making sure that we're doing the things that we know by protocol and standing order that we're supposed to, we're on a tight timetable here because time is muscle. The longer that bit of muscle goes without its oxygenated blood flow, the closer it gets to actually infarcting and dying, rather than just being ischemic and not really enjoying life at the moment.
Is the ischemic different from acute?
So we're going to talk acute versus chronic in just a couple of minutes. Acute really just means emergent. Acute means this is something that's happening right now.
Okay.
You know, when we draw the line sort of acute versus chronic, we talk about patients who maybe have some bit of chest pain all the time because of their coronary artery disease,
Okay.
versus patients who have never had chest pain before in their life, and all of a sudden I walked up a flight of stairs and now my chest is killing me and I can't catch my breath and I feel like crap and it feels like there's a ton of bricks on my chest, and you show up and they are sopping wet with sweat, cool and clammy to the touch, they are gray, and you look at them and you go, wow, they look like they're having the big one.
Wow.
That's your acute chest pain versus somebody who's like, I had a heart attack 2 or 3 years ago, and really ever since I've had some bit of chest pain almost every day. There's cardiologists, there's meds that they can prescribe to limit that, but that would be a chronic problem versus the patient who's having an acute chest pain.
You said acute means at the moment.
Yep.
Good to know. Noted.
So as BLS providers, we are going to talk a little bit here about using a cardiac monitor, because in the new education protocols and in our sort of day-to-day treatment, it is actually in your scope of practice to provide cardiac monitoring to a patient. Now, notice I said monitoring. We do not need to interpret EKGs. We do not need to be able to read them. We don't really need to be able to do anything other than put the leads or put the stickers on the patient's chest and do it appropriately. But just telling you put stickers here and put stickers there isn't going to cut the mustard, because the book is going to ask you questions and the registry is going to ask you questions. So we need to talk about this stuff a little bit. Who here has seen what an EKG looks like, either in the
Me.
hospital or on TV or anywhere?
Me.
All right.
Yeah.
So it's not a completely foreign concept, which is nice. So this is what they call a normal sinus rhythm, we'll say for argument's sake right this minute. It's called that because this P wave right here at the bottom shows the atria contracting. So those atria, those storage tanks, they contract and push blood down into the ventricles, and that is what's happening when we see that first little bump on our EKG rhythm strip. The next thing we see is what's called a QRS complex, that big, tall, narrow spike that we're going to look at. That QRS complex is when the ventricles actually contract. So we have P, QRS, that's the ventricles and the atria contracting respectively. And those things happen within like milliseconds of one another. The cardiac monitor actually slows things down a little bit so that you can actually see what's going on. But those things happen very, very close together. The next little bit we see, that next little bump after the QRS complex, is the T wave. The T wave is when everything relaxes. So P and QRS are when everything is doing their squeezing bit and sending blood here and there. The T wave is when the heart is now reloading and relaxing of the ventricles and getting ready for this whole thing to happen again. This is what the rhythm and the readouts or any of the things that you see on a cardiac monitor should look like, because that is normal. When we're going to look at a couple of strips here in just a couple of minutes, and you'll see the very, very easy to define difference between something that looks normal and something that looks way and completely wonky, and you look at it and you go, oh, it should not look like that, because this is what they should all look like. Now, depending how many happen in a minute is going to tell us whether we're tachycardic, bradycardic, or normal. Depending on the differences in what these waves look like is going to tell us when we actually, 2-3 years down the road, when you guys come back here for your paramedic class, whether or not there is that little P wave bit is going to tell you where the electricity is actually being generated. There's a huge laundry list of things that we can learn just by looking at a cardiac rhythm strip. And thankfully for you guys, and thankfully for me more likely, because it's like a 6-month class all by itself, cardiology. Cardiology is a big, big deal as far as paramedic education goes. That's why when Will was talking to you guys the other day, he said any cardiac or any respiratory, that's where a paramedic is really going to make the most impact. Because really, all we need to do is look at these and go P, QRS, T, everything looks sort of the way that it's supposed to. That's happy enough for me. What that cardiac monitoring is actually monitoring is the travel of electricity through the heart. That is what that machine is picking up. It's picking up the depolarization and repolarization of all that electrical current as it's moving millisecond to millisecond through the cardiac conduction system of the heart and getting ready to trigger and stimulate that squeeze of the ventricles in that QRS complex, and then relaxing, refilling, and reloading at the T wave to go ahead and stimulate another contraction. So now remember this picture. This is what normal looks like. We have a P, we have a QRS, we have a T. We're going to call this our normal sinus rhythm. When we look at the paper and we don't see normal or we don't see enough, that's when we start talking about things called arrhythmias. So this right here, what we're looking at, this is an abnormal rhythm, and it's only abnormal because of this one word on the screen.
Rhythm.
Nope.
Bradycardia.
What's bradycardia mean?
Slow
So it's
heartbeat.
slow. So we have a sinus rhythm, because if we look here, we have those P waves. That's telling me that this is a sinus rhythm. And bradycardia is just telling me that we don't have enough of them. It is below 60 beats a minute. And this is an arrhythmia purely just because the heart's not beating fast enough. This right here is a rate of 50. We have 5 beats on that piece of paper. It measures in 6-second intervals. So this is a heart rate of 50 beats per minute. So it is sinus bradycardia.
Can I ask a quick question?
You may.
So when it comes to arrhythmia syncope, if I'm saying it correctly, is
Yep.
that similar to the one we're talking about now?
It absolutely can be. Because let's get into some of the stuff we talked about yesterday and wiggle it into what we're working on today.
The shock.
Most of
Okay.
the time when a patient has a syncopal episode, it's relative to generally 1 or 2 causes. It's either a pressure problem or a rhythm disturbance. And they all circle their way back to not enough pressure. If your patient's heart rhythm or heart rate gets all out of whack and it's beating too fast, those ventricles don't have a chance to fill. If they don't have a chance to fill appropriately, the next heartbeat doesn't squeeze out enough blood. If that next heartbeat doesn't squeeze out enough blood, we have a problem maintaining pressure. We have a problem maintaining pressure and we stand up too fast. The next thing that happens is gravity helps us to the floor because get dizzy and woozy and down we go. That's a syncopal episode based solely on rhythm and pressure problem. You know, it can happen with dehydration or heat exhaustion and things like that. But really what we boil right back to every single time is we're going to have some sort of rhythm disturbance. That rhythm disturbance is going to cause us a problem with pressure, and that pressure is what allows gravity to help us come rocketing to the floor. Did that make sense?
Yep, that made perfect sense.
All right, good. So let's take a quick look at this one. And I want somebody out there to tell me something. Let's talk about what we have here in front of us. Now we know it's sinus tachycardia. Tachycardia means too fast. Do we have a P wave with each one of those complexes?
Yes.
We do. We got a little bump in front of each one of them. So that's a sinus rhythm because we got a little bump.
Mm-hmm.
We got one here, one here, one here, one here. Now tell me something about the rate.
It's way too fast.
Yeah.
If we have a 6-second strip, however many beats are on this piece of paper, We're going to multiply by 10. So 1, 2, 3, 4, 5, 6, 7, 8, 9,
110.
11. You got it, 110. So is that fast? Sure, that's fast. And might it have some cardiac output disturbances? Sure.
Yeah.
But this is not like crazy tachycardia. I mean, yesterday when we were doing that shock case study, by the time we were finished, our patient's heart rate was something close to like 130. So that would be 2 more beats wedged onto this piece of paper. So think of how much faster that would even look. So if a heart is beating too slow or a heart is beating too fast, cardiac output is going to fall. If cardiac output doesn't maintain what we need it to be, which would mean if it's not beating between 60 and 100 beats per minute and ejecting enough blood, pressure is going to fall. We'll see changes in our patient's blood pressure just based on the fact that their heart is either beating too fast or too slow. If a patient's heart is beating too fast to maintain the perfusion needs of the body, we're going to see some patient changes. We'll start to see some of that pale, cool diaphoretic skin that we talked about. Maybe when we're checking a radial pulse and we find that it's, almost too fast to count, that it also feels pretty weak. Well, it feels weak because we can't maintain the pressure because the ventricles aren't filling. And if the ventricles aren't filling, the heart's not ejecting enough blood. And if the heart's not ejecting enough blood, guess what? We wind up with a pressure problem. We wind up with a perfusion problem. And we get right back to all of the stuff that we talked about yesterday. And it's all just based on sinus tachycardia, sinus bradycardia, and a patient whose heart is not pumping appropriately to maintain enough pressure to actually perfuse the patient. All right, tell me what you noticed right away about this.
It's not sinus.
It's definitely not sinus. How come?
There's no beat before the next one.
Yeah, and is it nice and narrow and spike looking like what the typical QRS complex is?
No.
No. This is called ventricular tachycardia. Think back to the beginning of this lecture and somebody tell me, where does the heartbeat normally start from? Which part?
The
The SA
ventricles.
node.
The SA node. Yeah, the SA node is the typical pacemaker of the heart. The sinoatrial node stimulates a sinus rhythm. Where do we think ventricular tachycardia starts?
The ventricles.
Yeah, the ventricles are what's actually creating this impulse. So way south of where this electrical current is supposed to start, it's actually starting. And we wind up with these great big giant wide complexes. And the problem with these is there's a lot of them. 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. That's
Is he having a
190.
heart attack?
Say that again?
Is he having a heart attack?
So this isn't telling us that the patient's having a heart attack. Ventricular tachycardia can actually still have a pulse, albeit not for long. You could actually feel a patient having an actual pulse and an actual blood pressure in ventricular tachycardia. Sooner or later, it starts to becoming non-perfusing rhythm. A non-perfusing rhythm means that patient goes into cardiac arrest because their heart is beating way too fast and way too inappropriately to actually get any blood out and cause any perfusion to happen. If you look at this rhythm here on the paper. It's very, very regular. It's very, very even. It's nice and marched out. But this is not going to last for very long. This is a patient, and this is actually one of the two rhythms that your AED will pick up and read and shock. AEDs will shock ventricular tachycardia, and AEDs will shock ventricular fibrillation, which is the next one we're going to talk about. But this patient could still have a pulse for a very short amount of time. This just means the ventricles are where this impulse to beat is stimulated from, and it is happening way too fast. Now let's talk about this. What do you notice about this piece?
This is what they call VFib.
It is. This is ventricular fibrillation. To fibrillate means to just quiver. The ventricles are actually in the chest, just kind of jiggling like you had a bowl of gelatin or jello on the table and you whacked the side of the bowl and you just watch it kind of quiver and shake back and forth. This is what the ventricles are doing in ventricular fibrillation. This is the other rhythm that your AED will actually pick up and read and advise you to give a shock. And when we give a patient a shock because they're in ventricular fibrillation or ventricular tachycardia, everybody talks about how we're jump starting the heart, but that's not what we're actually doing. An AED, when it's ventricular fibrillation or ventricular tachycardia, is the human version of turning it off and turning it back on again and hoping that it works. We introduce 200 joules of electricity into this cardiac rhythm right here, trying to make it go away. We actually try and stop that from happening, because if the ventricles are just in the patient's chest, wiggling and jiggling and quivering away, are they squeezing anything out?
Nope.
No.
No, there's no actual organized beating. There's no squeeze. There's no cardiac output. Absolutely zero to support perfusion is happening at this point. And it's because the ventricles are in there just kind of doing their own thing. The electricity, when the AED says shock advised and we push that button, is going to pass from the SA node through the AV node, down into the bundle branches, out to those Purkinje fibers, and cause the entire heart to depolarize all at once. And in jump stopping the heart like that, the next thing we hope to see is an organized rhythm again. Might not be great, might not be anything we really appreciate looking at, but we can't have this stay. Because if ventricular fibrillation hangs around for an extended period of time, and all of that electrical activity is just chaotic and not doing the things that it's supposed to, ventricular fibrillation turns into this.
Flatline. Asystole.
This means there is no longer any electrical activity. No P wave, no QRS complex, no T wave, no electricity going from the SA node to the AV node to the bundle branches to the Purkinje fibers. This patient is dead. We're still going to do cardiac arrest management, so we're still going to do our CPR, 30 and 2 at a rate of 100 to 120 beats per minute, 2 to 2.4 inches of compression on my patient's chest. Every 2 minutes, that AED is going to analyze that electrical activity in the heart. And with this rhythm in particular, it's going to tell us no shock advised, because the AED isn't picking up any electrical activity. We're not actually putting jumper cables on the patient. We're really just resetting them, hopefully. So from now on, anytime you see on TV where they're shocking somebody with a rhythm that looks like this, tell all your friends and family that that's garbage, because we don't do that.
So what? Oh, we can go first.
No, it's okay. Go ahead.
In what cases would a doctor use a precordial thumb?
So first, I'm going to start with a little bit of history. If we were to hand an EKG strip to 12 different cardiologists, you would get 12 different opinions about what was wrong with the patient. So that being said, precordial thump is one of those things that some people think is great and very helpful. Some people think is, witchcraft and never did anything. And take your pick as to which side of it you're on. The precordial thump is everything that it sounds like. You are going to take your elbow and pretty much put it in your patient's belly button, and then just allow your hand to drop in the center of their chest. You can
What?
read all sorts of stuff online as to whether this works or whether it doesn't work. But if a patient is in the very, very early stages of ventricular fibrillation and you don't have an AED available, there has been times where just hitting the heart, just enough, just right at the exact moment, it's like hitting the lottery. But there has been situations where a precordial thump early in a cardiac arrest has actually stopped a patient in ventricular fibrillation. When would a doctor actually use it? The answer to that is not very often, because it has to be such a specific set of circumstances for that to actually be effective. But yes, it has worked.
Okay.
Holy buckets, it's almost 9:30. All right. Myocardial infarction leads to actual physical death of that piece of heart tissue, and our acute coronary syndrome just continues to progress from there. So we're going to have a couple of terms here. And those terms are angina pectoris, unstable angina, myocardial infarction, myocardial ischemia. And those
Wow.
are what is covered by our acute coronary syndrome and our acute coronary syndrome protocol. Angina pectoris is just a fancy Latin term for pain in the chest. That's what that means. Sometimes I don't know why medical terminology has to be the way that it is, because, they call Latin a dead language for a reason, but, we got to learn to speak some of it. What do you think unstable angina means?
That it's not stable pain, not constant.
Yeah, it's not constant. Unstable angina is chest pain that we can't really put our finger on something that the patient did to cause it. At the end of the day, chest pain is chest pain and the world is round. But unstable angina is just that. It's my patient was sitting there minding their own business, and then poof, all of a sudden, terrible, horrible, no good, very bad chest pain. It's not my patient was running on the treadmill for the first time in 25 years and got a little short of breath and started to have some difficulty breathing and some pain in their chest. Because my patient actually did something to make that chest pain start. So when we ask the P question of our OPQRST, or the events leading up to this chest pain beginning, if my patient tells me, well, I was taking a nap on the couch and this terrible pain in my chest just woke me up, and then we called 911 right away, that to me is, all right, something's cooking here, something's going on, and this patient's not likely to have a very good rest of today. Whereas if my patient was on the treadmill for the first time in 25 years, trying to run like they did when they were a kid, and chest pain all of a sudden came to find them, and they got off the treadmill, and the P question comes up, and I say, does anything make this pain better or worse? And my patient says to me, yeah, it was terrible when I was running on the treadmill, but now that I've been resting for a few minutes, I feel better. Both of these patients are having chest pain, but which one do you think is sicker?
The one that was sitting on the couch.
Yeah, the one that was minding his own business and not aggravating his heart and his coronary artery disease. So we can kind of look at the entire picture of our OPQRST and our sample history and start to figure out how all of this fits together. Because you're spot on when you say the guy who was just laying on the couch, lounging around, having a normal, regular afternoon and got waylaid by chest pain is arguably probably sicker than the patient who was running on the treadmill, not used to that kind of increased oxygen demand, started to have some chest pain, stopped, and their chest pain went away. Both of them are having chest pain. Both of them really arguably are having unstable chest pain. But one of them is explainable and one of them came on for no reason. So myocardial infarction, I feel like we've covered that pretty well. MI, myocardial infarction, is going to be your patient who is having a real for life heart attack. Myocardial ischemia is your patient who is having some chest pain from tissue aggravation from lack of perfusion. So this is heart muscle that has not died yet, but is not doing well. It is suffering the consequences of this coronary artery disease and this acute coronary syndrome. And to us, for the most part, we're going to talk about how they present in very much the same fashion. But first, let's talk about what we're going to do for it. We give nitroglycerin. What do we give nitroglycerin for?
I thought we assist with nitroglycerin.
Yeah, you're right. Well, yes, we do assist with nitroglycerin. But at the end of the day, it's
Hand over hand. Hey, I'm
yeah,
gonna give you this.
we're not actually going to physically put this pill tablet underneath our patient's tongue, but we help them with it. It's all right. What is
It's
this drug called?
assisted for for when they're having chest pains, like they're having well, don't their heartbeat have to be first that their systolic heart rate has to be over 160 or something, or under 160, something like that.
160 is a little high.
Okay,
So,
120.
yep, there you go. On your protocol sheet, it's going to tell you that the patient's systolic blood pressure has to be above 120.
Above 120. Systolic
Here
blood
in
pressure
the state of
above 120.
Massachusetts, that is our point of reference. Your book probably tells you something different because I believe the textbook still says a patient with a systolic blood pressure of anywhere from 90 to 100 can still be a candidate for nitroglycerin.
Okay.
If you're taking a test in front of a computer, your number is whatever the book tells you.
90 to 100, whatever the book tells me.
If you are taking a test here in class or you are at the state practical exam, the number is 120. Your textbook is written to the national standard. They don't cover all of the individual state protocols. Nitroglycerin can be a dangerous medication. Nitroglycerin given at the wrong time to the wrong patient can actually kill them. So what's the rest of your protocol? Somebody tell me, what's the dose of our nitroglycerin tablets?
Is it 0.3 milligrams?
You're close. 0.3 is epinephrine.
Three tabs.
So it is 3 tablets spaced 5 minutes apart as long as the systolic remains above 120. And it is 0.4 milligrams. So our 3 tablets includes anything that the patient gave to themselves before we got there. So the total dose in our encounter with this patient can be no more than 1.2 milligrams. It's 0.4 the first time. We reassess them in 5 minutes. We recheck their blood pressure. We ask them if the nitroglycerin helped. If it did and their systolic blood pressure remains above 120, we assist them with another nitroglycerin. We wait 5 more minutes and we recheck their blood pressure and reassess our patient. And if their blood pressure systolic is still above 120, we're going to give them another nitroglycerin. And that's it, 3 total. And what is
Isn't
it?
there a spray form of nitroglycerin?
There is a spray form of nitroglycerin, and whichever one the patient happens to use, we can assist them with either one because the spray is also a 0.4 milligram metered dose.
And what was the max dose? 1.2?
1.2. So what is it that I'm trying to do with this nitroglycerin again? Because we've gone through our indications, we've gone through when we would use it, we've talked about the forms. What's it actually doing?
Dilating
Dilate
the,
blood vessels.
yeah.
Okay, dilating the blood vessels in an effort to do what?
Get the blood flow.
You got it. We're trying to get the blood flowing past where that clot is. By dilating those blood vessels, some perfusion is hoping to sneak by. When are some times that we wouldn't give this nitroglycerin? Because knowing when not to give something is equally as important as knowing when to give it.
When they got
If
low
they
blood
took
pressure.
All right. I heard both the answers I was looking for. Somebody said low blood pressure. So if you're out providing care in the city and their blood pressure is below 120 systolic, we're not going to give nitroglycerin. Why do you think Massachusetts holds us to a higher number?
because they got a lot of cheese eating burger people out here.
Well, fair enough, but it's actually even something a little bit simpler than that. Think about where we live. We are no further than 10 miles from some of the fanciest hospitals in America. You can't
Oh,
throw a rock down the street without hitting a doctor. So there's no
true.
reason for us to do things that could actually prove to be dangerous for our patient when we can bring them to an emergency room. And a lot of emergency rooms and a lot of hospitals now have a cardiac catheterization lab where they can
Yeah.
actually go in and restore perfusion to this patient's heart. I'm sitting no more than 2 miles from one. So we don't really in Massachusetts play things kind of fast and loose because we have the ability to get someone in short order to somewhere where this myocardial infarction and this myocardial ischemia and this acute coronary syndrome can be figured out and worked out in a controlled and safe environment. So we stay with the number of 120 millimeters of mercury for a systolic blood pressure because really at the end of the day, it's safer for my patient and not going to make them any worse. So we've got our indications, we've got our contraindications. The other big one was a patient who's taken any ED medications within the last 48 hours. We've talked about the forms of this medicine. We've talked about the way that it works, how we're going to assist with it. Where does this pill go? What do we want our patient to do?
Under the tongue.
Under the tongue, it is a sublingual route of administration. It goes under their tongue and it melts. Some of the side effects now are patients likely to complain of some tingling in their face or in their lips or under their tongue. They're also going to complain of a bit of a headache. Nitro is a potent systemic vasodilator. So it's going to dilate all of their vasculature, including the vasculature up in their head. So they're likely to have a bit of a headache. They're likely to complain of some tingling under their tongue. And we expect to see a drop in their systolic blood pressure. And we expect, hopefully, that their chest pain improves a little bit. And maybe some of those signs and symptoms of hypoperfusion start to go away. My patient's maybe not gray and sweaty anymore. Maybe my patient is able to breathe a little bit easier and feels a little bit better and isn't quite as anxious. So we're not seeing some of those level of consciousness changes because we've used this medication appropriately and we have actually improved, for the time being, their acute coronary syndrome. So let's talk for just a minute here about how we can sort of recognize the sort of subtle differences between a patient who's just having angina or just chest pain and a patient who's actually truly having some sort of ischemic or infarct changes to the muscle in their heart. So on the left here, we have angina pectoris. On the right, we have myocardial infarction. And if you look here, we have pain in the same places, substernal, meaning just below the sternum and across the chest. Our radiation, neck, jaw, arms, back, and shoulders. Patient who's having a myocardial infarction is likely to have the same complaint, pain that radiates into the neck, jaw, arms, back, and shoulders. What's this asking? What question is nature of the discomfort? Look at the descriptors that they're using. What question in my OPQ or ST is that?
Quality.
Yeah, they're going to tell me that it's a dull, heavy discomfort or a pressure or a squeeze. Patients who's actually having a heart attack, a myocardial infarction, is likely to have the same kind of pain, but on a much greater scale. So your angina patient generally is complaining of some chest pain, but if we look at the time, usually 2 to 15 minutes and subsides when the activity stops. There's your unstable chest pain. He's got a dull, heavy discomfort that radiates into the neck, jaw, arms, and back. It's substernal, right underneath, right middle of his chest. But activity stops, chest pain gets better. With my patient who's having a myocardial infarction, they didn't necessarily even need to have any activity first and foremost. But look what doesn't happen. My angina patient, activity stops, chest pain gets better. My heart attack patient, does this say anything
It
about their
doesn't.
chest pain getting better? Will we talk about the
No.
provoke or palliation of their chest pain?
No.
No, that's because this patient's infarction, their heart muscle's actually dying. This
No.
patient is ischemic. Look, we don't see any of those color, temperature, condition changes. Usually none. A myocardial infarction patient, pale, cool, diaphoretic. Do you see all the places that some of this touches as far as how we assess a patient?
As in the history and
Yeah,
getting your primary assessment in the
yeah.
beginning.
History, the primary assessment, we are seeing right here in front of us. This is like the case study that we did yesterday. We are actually now watching ourselves walk through our assessment of this patient and trying to differentiate ischemia, infarction, and actually getting down to how are we going to treat this patient. And if we look at it, we treat them all the exact same way. If your patient is having chest pain and it's not from some sort of explainable traumatic event or injury, guess what they get? They get nitroglycerin and they get aspirin. Now, aspirin we haven't talked about yet. Nitroglycerin, we went through the wheres and what fors of that. What about our patient who's having chest pain and we're going to follow our protocol and we're going to give them aspirin? How much do we give them? How do we give it? And what are we giving it for?
Milligrams for baby.
All right, 324 milligrams for baby aspirin. You got it. What are we going to tell them to do with it?
Chew it.
Chew it. How come we don't want them to just swallow it?
You don't carry water?
Well, that's
It's
true.
absorbed faster.
It gets absorbed faster. If your patient takes those pills, puts them in their mouth, and swallows them, it's going to take somewhere between a half hour and 45 minutes for that aspirin to do its thing. If they're already broken down and crushed up and chewed when my patient gets them down into their stomach, it's almost instantaneous that that winds up into the bloodstream. And remember, time is muscle. And what are we trying to do with that aspirin?
It inhibits platelets from clumping together.
It does. When this aspirin is not given for its pain relief quality, aspirin is not going to affect one bit of difference in how uncomfortable this patient is. But it inhibits the platelets' ability to clot and clump together. And if they can't clump together and they're not forming as big of a clot, we're sneaking some blood by. And maybe that ischemia never turns to infarction, just based on something so simple as giving this patient 4 81 milligram tablets of aspirin to chew up and sending them to the emergency room. Aspirin is way more important than nitro, because nitro is really just going to make them feel better. It's not going to help really a lot. Aspirin is what's going to make that clot stop getting bigger. And if we can stop that clot from getting bigger and some blood is still getting by, we've now stayed in the level of ischemia and prevented infarction. When wouldn't we give aspirin to a patient?
If they have some kind of GI bleed.
All right, so an active GI bleed, I like it. What's the other time?
They have ulcers.
So yeah, so active sort of peptic ulcer disease. So yeah, anything that's gonna sort of stimulate their GI system to bleed a bit more. And there's one other thing.
And allergies.
Allergies, right. They're already having a bad enough day. I don't need to give them an allergic reaction on top of it. So if they say they have an allergy to aspirin, they don't get it. If they say they currently have a gastrointestinal bleed, or they have complaints that are pointing you towards some sort of GI bleeding, no aspirin. Other than that, your chest pain patient is always going to get aspirin, 4 81 milligram chewables to a total dose of 324 in an effort to stop that clot from getting bigger. Our patient who gets nitro is only a patient who has been prescribed nitroglycerin, whose systolic blood pressure is above 120, and they have not taken any erectile dysfunction medicine within the last 48 hours. And that right there is pretty much verbatim the protocol from your piece of paper that you got the other day in class, because that is how you'll treat every single chest pain patient from now until the end of time. Any questions at the moment? All right, then we're moving right along, because the last little bit of stuff we have to talk about as far as cardiac disease goes is going to be aortic aneurysm and aortic dissection. So the aorta is the largest and really the most important artery in your entire body. The aorta carries all the blood from the left ventricle of your heart to everywhere in your body. It carries every drop of blood that has been oxygenated and is headed downstream to provide oxygen to the tissues from the heart to everywhere else. It feeds every other bit of vasculature in your person. When we talk about an aortic aneurysm, it's like when we talk about aneurysms anywhere else, except it's way nastier of a problem. Aortic aneurysm is generally caused by uncontrolled, unchecked hypertension. That hypertension causes a weakening in the wall of this artery. So you saw all that smooth muscle and all those different layers and linings in all of these arteries, and the aorta is no different. It's got all of these linings here, and it's tough and it's fibrous and it's meant to withstand all the pressure. But when the pressure in your arterial system from, pathologic hypertension is too high for a long period of time, the walls of that artery start to break down. And when those walls start to break down, they weaken, and that pressure remains high, and you start to get this little like bulge, this little balloon off of the wall of that artery. And soon enough, if it's not noticed and blood pressure isn't fixed and corrected and your patient remains hypertensive for a long period of time, that artery isn't going to be able to stretch any further. And when it gets to a point where it can't stretch any further, it's going to rupture. And what does the aorta carry again?
All the blood
Blood?
supply.
All the blood supply. So when that aorta ruptures, very, very rapidly, it's going to lead to complete and total lack of pressure, lack of blood volume, hypovolemic shock, and rapidly your patient will bleed to death internally before a single drop of blood ever hits the floor. It comes with some pretty specific signs and symptoms. Our aortic aneurysm generally is a patient who's got significant high blood pressure and generally complains of this sort of tearing, burning sensation or a ripping sensation in their back. Normally, we do not find anything really on physical examination when we are, say, palpating a patient or doing our physical exam during our secondary assessment. We could, if this aortic aneurysm is in the abdominal aorta, just before it ruptures, the final stage of this getting ready to blow is we'll feel a pulsing mass on our patient's midline, right on the aorta. If you find one of those on palpation, only poke at it once, because this is getting ready to rupture, and this will absolutely lead to your patient being unresponsive in short order, and you'll be working a cardiac arrest. The guy who taught my EMT class when we were talking about aortic aneurysms and abdominal aortic aneurysms, or the abbreviation for that is AAA, he said that he responded to a patient who was complaining of that sort of tearing sensation in between their shoulder blades and had chronic hypertension. And she looked up at him at one point during his assessment and said, "I think I'm gonna," and hit the floor dead. Never even got to finish her thought. She was immediately in cardiac arrest because this aortic aneurysm had let go. And that's all she wrote, "Won't be down for breakfast," because it carries every drop of blood everywhere it goes, every beat of your heart for all of your existence. So one of the take-home messages for this lecture is, if you have high blood pressure, go see a doctor. High blood pressure is a silent killer. It is really bad for your eyes. It is really bad for your kidneys. You don't want one of these things to happen to you, because it could happen in the operating room, and you may bleed to death before they could actually save you. Is this repairable? Sure. Can they do something about it before it ruptures? Sure. But if you have high blood pressure, go see your doctor. Aortic dissection is sort of the same thing, but only a little bit different. Instead of hypertension causing a bulge and an aneurysm to form on the outside of this artery, we have a tear in the lining, and blood is actually now leaking into the interior layers of this artery, of the aorta. And that dissection, that tear in the wall, is also going to cause a bit of a tearing, ripping, burning sensation. Your patient may have the complaint that it feels like it goes right through them like a lightning bolt. Couple of the things to be on the lookout for with a patient that is hypertensive and is complaining of those kinds of pain is you may have vastly different blood pressures on their left arm versus their right arm. That is something to be suspicious of. Do you think that normally, generally, on your average every day, if I took somebody's blood pressure on their left arm and it was 140/92, that on their right arm it should be 100/60? Or should it be close to the
No,
same normally?
it should be close to the same.
If you take a patient's blood pressure and it's 140, 150/92, something like that, grossly hypertensive, and the other arm is way different, start asking them questions about their medical history with hypertension, about are they having any pain in their chest? What does it feel like? Because this is something to be on the hunt for if you're getting those weird sort of wonky measurements. Because that should sound funny, right? Because it is. That's not normal. That's definitely problematic in some way. Yesterday when we hit cardiogenic shock, we saw on the sheet on the lecture a little bit about heart failure. And cardiogenic shock, regardless of what flavor of the week it is the heart actually failing to meet the needs of the body and not providing and doing its job as a pump well enough. There is a multitude of things that can cause the heart to fail and not be able to do its job. High blood pressure is yet another one. High blood pressure is terrible at causing this left ventricular hypertrophy that you see on the screen there, where the walls of that left ventricle get really, really thick. And look at what you notice in this picture. When the walls of that left ventricle get thick, it intrudes into the space, because this is how much space there's supposed to be in the left ventricle. It's supposed to be able to fill up and eject all of that blood. And instead, there's only this tiny little bit of room, so that it means it holds less blood. And if it holds less blood, it ejects less blood. And if it ejects less blood, there's less cardiac output. And if there's less cardiac output, we're going to wind up with a perfusion problem. And if we wind up with a perfusion problem, we wind up right back at cardiogenic shock like we talked about yesterday. And that right there is left-sided heart failure in a nutshell. So I want you guys to, we're going to stay in the vein of plumbing here for a minute, because we're going to talk about fluid. If you have a clog in the drain in your sink and you continuously run that sink, where's the water going to back up to?
You're gonna back up into your toilet or your sink or your whatever.
Yeah, so if I have a clog in the sink and I run the water's just going to come up, right? And it's going to back up pretty much to where it came from.
Mm-hmm.
Heart failure is the exact same mechanism. If this right ventricle is failing to pump blood appropriately, and I have right-sided heart failure, where's that blood going to back up to?
Right back up into the veins, the artery, the space.
Well, yeah, what's above the right ventricle?
The aorta.
No. Here, I'll put the arrow on it. So I'm saying right now, we have heart failure here. This whole right ventricle is failing. Where does the blood in the right ventricle come from?
The right atrium.
The right atria. Fluid backs up to where it came from. So if the right ventricle fails, fluid backs up into the right atria. And then the right atria gets filled. And then blood backs up to where it came from. And the superior and inferior vena cava wind up getting filled. If your patient has right-sided heart failure, you're going to see signs and symptoms of hypoperfusion. you're going to see signs and symptoms of poor cardiac output, and you're also going to see distended jugular veins because fluid backs up to where it came from. So it's going to go right ventricle, right atria, vena cava, and right up into those veins in the neck, because it just backs up and backs up and backs up, and you'll see these great big giant veins sticking out of the side of your patient's neck. So staying with that same thought, and remember, blood backs up to where it came from, right? If we have left-sided heart failure, that means over here, we're failing to meet the needs. Where's that blood going to back up to?
The lungs.
Yeah, it goes into the right atria, and then it backs up into the pulmonary circulation and backs up into the lungs. Your patient who's having a left-sided heart failure is going to complain of some respiratory distress. They're going to probably be beet red and hypertensive and breathing rapidly. And when we listen to their chest and we get those lung sounds, we're going to hear that crackling noise that Dennis talked to you guys about, because it's going to sound like there's fluid in their lungs. Want to know why? Because there's fluid in their lungs that the left ventricle should be pumping out. And that's what's causing this problem. So just remember, the way that that blood travels and the fact that it's going to back up during heart failure to wherever it came from. So our right-sided heart failure backs up into the venous side of the system. We see those distended jugular veins, signs of poor cardiac output, signs and symptoms of shock, and it's cardiogenic in nature. Our left-sided heart failure is going to have respiratory distress, probably hypertension, probably a rapid heart rate, and you'll hear that crackling, wet sound in their lungs because their lungs are filled with blood. That's the left ventricle is failing to pump around. How was that? Lots of problems, isn't it? Problems everywhere. So what do you guys have for questions? Let's hear some. If I don't hear any questions, I expect that you guys understood.
Hello, can you hear me?
Yep.
Okay. Hypertensive. Oh, how do I say it? Pulmonary hypertension. Does that when somebody has that and then is having chest pains, we should think about what you just explained about that fluid being backed up?
Yeah, that could absolutely be part of it. Really though, there's not much we can do for the management of heart failure. There's not much we can do for the management of pulmonary hypertension. What we spend a lot of time with patients like that doing, and whether it's congestive heart failure, left-sided heart failure, right-sided heart failure, pulmonary hypertension, they're all just fancy words to us that are going to realistically going to be a problem as far as patient management goes. We don't have any secret meds that's going to fix it. We don't have any, real like effective type treatments. We need to focus on our patient assessment. Focus on the signs and symptoms that your patient is presenting to you and see if there's anything you can do to make those better. Your left-sided heart failure patient who is having some respiratory distress and having a difficult time breathing, we're going to manage that patient with oxygen. We're going to manage that patient possibly with ventilation. We may have to use a bag valve mask. We're going to maybe put that patient on some CPAP to try and force those alveoli open and force them to be available for gas exchange, even in the presence of all of that fluid. Because really, all we're trying to do is get that patient to the emergency room in as good a shape as we found them in. So we have to manage their signs and symptoms, take care of the respiratory compromise that comes along with a lot of this stuff. If we've run out of actual treatments for their actual problem, so all right, fine. They had chest pain, so we gave them some nitro, we gave them some aspirin. It's probably left-sided heart failure, maybe it's something different. Flip a coin, what difference does it make? It's a chest pain patient who is now presenting to me with respiratory compromise. All right, their respiratory rate is 40, and I'm seeing almost no chest rise and fall. Is that going to be adequate to sustain them as a person? We have no chest wall movement in a patient who's breathing 40 times a minute.
Yeah.
That's not helping them, right? So what would you do to help that patient?
Ventilate.
Give them.
Whoever said it out there is right. We're going to ventilate them with a BVM, one breath every 5 or 6 seconds. And we are going to rapidly move towards transporting this patient to the emergency room, where they can start doing some of the more invasive and some of the more expanded out things to try and make this patient better. At the end of the day, if somebody's heart is so diseased that they're having all of these problems, treatment is really the only option. Treatment is not going to reverse or fix or correct necessarily their issues. They may need a heart transplant. They may need a lot of work under the hood with a ventricular assist device or something that will get them healthy enough so that they can receive a heart transplant. But we're going to manage the signs and symptoms so we can get them to the emergency room in a good enough condition so that any of that stuff will even be an option. All right, what time is it? It is 10:40. We've been at this for another hour. Good Lord, I can just go on and on and on. We're going to take another break. And when we come back, we will have just enough time to do the immunology lecture, and we'll talk about anaphylactic shock. And then tomorrow, we're going to do the respiratory lecture with what we had scheduled for tomorrow anyhow. So up goes the timer, and we will be back in 15, and we'll get through anaphylaxis. All right, folks, we're back again. We are now going to talk immunological emergencies. This is really just going to encompass anaphylaxis because that's the big one. This is where we're going to actually be able to see ourselves in a very short amount of time save a patient's life for real. Anaphylaxis is one of the true priority one screaming lights and sirens emergencies because these are patients who are rapidly deteriorating, declining, and really trying to reach their expiration period in a very, very short amount of time. Immunological emergencies, the way they work when we talk anaphylaxis is the body itself is attacking its own self on many, many fronts and taking out all of our important body structures, all of our important body functions, and it just continues to feed that problem and spiral out of control in a very short amount of time. And it's all as a result of the body doing something that it does day in and day out to keep us healthy. We talked about the white blood cells when we were talking about the content and makeup of our blood. And the white blood cells are the culprit and the cause of this whole entire problem. So this is really a legitimate look at the way anaphylaxis progresses. So we see normal Will Smith there in the upper left-hand side. And then, oh, it looks like he's a little itchy, a little uncomfortable. And he looks like he's a little more itchy, starting to get a little swollen. And in this last picture, we look at him and it looks like he has been beaten with a sack of doorknobs because his face is all swollen, his eyes are all puffy. And that is one of the main mechanisms that is in play here when we talk about anaphylactic shock and a true anaphylactic reaction. We need to figure out sort of where the defining line is with what's going on and how it's going on, and is it anaphylaxis or is it just an allergic reaction? And it's a lot simpler probably than it really sounds at this point, because when we talk about an allergic reaction, they all start the same way, whether it's an allergic reaction or anaphylaxis. The body is exposed to something that it has been sensitized to, is exposed to something that it is allergic to. That's called an allergen. Allergens are any substance that's going to trigger the body's immune system, specifically those pesky white blood cells. That allergen gets in, the body identifies it as either self or not self. In this case, the body is sensitized to it, it's allergic to it, it is identified as not self. That allergic reaction, now whether it is localized or systemic, is going to be the big deal. Your local allergic reaction, think of if you're not allergic to bees, getting stung by a bee, what happens?
Typically, nothing happens. You get a bee sting, you pull the stinger out, you're fine.
Right.
If you're allergic, you go into looking like Will Smith within a couple of seconds or minutes.
Yeah, a typical bee sting for someone who's not allergic. You get stung by the bee, it hurts, it's a little uncomfortable, might get a little angry looking, might get a little swollen, might be a little itchy. But that's the localized reaction to the venom that that bee just injected into you. All the same things happened. The white blood cells got called into the area. They walled off that area because you were injected with a toxin. And the white blood cells got about the business of eliminating that toxin from your body. But it was only local because it was only a regular allergic reaction to something that you should be allergic to. It is a venom. If you are allergic to bee stings, what happens is you get that sting, the localized allergic reaction starts, and then the white blood cells go wahoo, and they go running around like cowboys, deciding that everything's got to go. They release all of these chemicals that create all of these additional problems. They create swelling, they create vasodilation, they create leakiness in the capillaries. So now you have a tank that is too big, you have absolutely no pressure, Your airways are swollen. Your mucous membranes are all swollen. You have almost no ability to move gas in and out or to get blood round and round, and it just keeps going. And we have something that fixes that problem really quite simply. But let's get into allergens. What can we be allergic to? Well, short answer, absolutely anything. Your body can become sensitized and stimulate an allergic reaction to anything that there is that is not part of your person. If it's organic materials we're talking about, we're talking things like pollen and mold and dust, things like seasonal allergies, poison ivy. Normally, just a minor reaction. You get sneezy, you get a little itchy, and you take a Claritin and life goes on. Rarely do these organic type materials present as a true anaphylactic reaction where the immune system just goes wild and out of control and tries to kill the patient. Food is a big one. 30% of all the deaths attributable to anaphylaxis are related to food. So this can absolutely be severe and systemic. Why do you think it takes a little bit longer for a food allergy to appear sometimes?
To digest?
Yeah, for the same reason we have our patient chew aspirin is the same reason that a food allergy doesn't always present itself the minute somebody puts peanut butter or shellfish in their mouth, because it has to get down into the stomach acids, it has to start to digest, and it has to get out into the bloodstream. But once it gets into the bloodstream, that allergic reaction becomes systemic. That blood that has got the shellfish or got the peanut butter in it is being pumped everywhere and delivering those nutrients to the far reaches of the body. And we will start to see actual systemic results from that allergen being introduced into the person. Common food allergies, and some of them are getting more common, some of them are getting less common, but realistically can be anything. The big ones that are the most detrimental to our patients more often than not are going to be our shellfish, our peanuts, and our tree nuts. These are things that happen quickly, they get out of control fast, and these are the patients who, when they accidentally eat, a cookie or a baked good that had peanut dust somewhere near it, wind up in trouble and wind up in trouble quickly. Next on our list is medication. Medication allergy or anaphylaxis can occur from any route of administration. Doesn't have to be an injection, can be meds that people are taking orally. Depending on how this patient takes the medication is going to depend on how fast it presents itself. If you are to take something intravenous that you're allergic to, it winds up as a systemic anaphylactic reaction before that needle can even get out of your skin, because that blood is constantly going round and round and round and round and round and round. And that medicine that you were allergic to almost immediately starts to cause some of those systemic reactions. If it's an oral medicine, it's going to be just like aspirin and just like a food allergy. It's going to take time for your body to break down that pill and get it out into the bloodstream and spread it far and wide. And then we see that anaphylactic reaction starting to develop. Chemicals, makeup and perfume, things like that, dyes, latex, you name it, just about anything. I personally, when we used to wear latex gloves, I'm allergic to latex. So I could write my name on my arm with a latex glove, and it would be swollen out and welty and itchy from there on out until I either took a Claritin or a Benadryl or something like that. Generally speaking, yes, can these be severe if they're things that you inhale and they get down into your lungs and cause problems there? Absolutely. But a lot of the times, people understand that they are allergic to these things and stay away from them. That happens with a lot of these anaphylactic and allergic reaction type causing allergens. Very infrequently, I personally have a story. My father-in-law is allergic to shellfish. and loves shrimp cocktail. One of the very first times I met him, he was eating shrimp and itching like a dog and like kind of coughing and clearing his throat. And I thought I was on candid camera because he knows he's allergic to shellfish, but he says, it's not that bad, as I'm watching him scratch his face and try and drink something to get, his airway lubricated and working again. And I'm standing there watching and going, this guy is out of his trees. Because I'm an EMT, my wife is an EMT, it just doesn't make any logical sense to me that if you were allergic to something that kills 30% of the anaphylaxis patients that are killed in our system, that you would intentionally expose yourself to it. Next on the list of things we can be allergic to, anything that bites or stings and injects venom. Doesn't have to be bees, hornets, wasps, can be ants, spiders, you name it. Whatever the venom is, if you have an allergy to it, you will develop an allergic reaction. Whether it is localized or systemic is yet to be seen. The important bit of information here is that these stingers can actually disseminate venom for up to a half an hour. When we find a patient who's allergic to bee stings and still has a stinger in them, we want to make good and well sure that we remove that stinger, because bees leave it behind, and they also leave behind the muscles, nerves, and venom sac that just continue to inject that poison. If we're going to remove a stinger from a patient, we don't want to squeeze the end of it. Why do you think we don't just grab it with something and squeeze it and pull it out?
Because you're going to squeeze more venom into the person.
Yeah, we're just going to give them a higher dose. You need to take something like, they show a credit card here, a business card, a tongue depressor or something like that, and use it to scrape along the skin to wipe that stinger out, as opposed to grabbing the end of it and squeezing. This can be the same for even some of the more poisonous things that we think of. I used to watch a TV show called Fatal Attractions, and it was people that kept like lions and tigers and the world's most venomous snakes as pets. And these people would routinely be bit by a venomous snake, vipers, rattlesnakes, you name it. And they wouldn't, most of the time, die from the actual venom that was being injected. Most of the time, they would either die of one of two things. They would have a septic reaction to whatever the bite was, or they would have an anaphylactic reaction to the actual toxin itself because their body had developed an allergy to it. And they would wind up dying from anaphylaxis, not from the typical thing that you would think of the actual poisonous venom that was injected into them. So there's the hows. There's the hows. Now we're going to talk about the differences between a localized allergic reaction, which is just a non-severe, non-systemic, pretty easily dealt with allergic reaction, and anaphylaxis, which is a true life-threatening emergency. Our localized allergic reactions, definitely not as concerning. When those white blood cells go out, they release a bunch, the immune system releases a bunch of histamine. Histamine is going to cause the itchiness. Histamine is going to cause some of the other symptoms that we see with our allergic reaction patient. We may see some signs of allergic reaction on their skin, like we'll go back to the bee sting. You may see a little bit of what they call urticaria, that red and white blotchiness around where your patient was stung by a bee. They may even experience some GI upset. Histamine is one of the major chemicals involved in digesting food. So if your body is releasing a whole bunch of histamine, that histamine is going to start to upset our patient's guts a little bit. All of these things don't have to happen at once. These are normally one-offs when we're talking a localized reaction. So we'll start to see some of this urticaria. Here's what it looks like. This is a great picture of what hives or urticaria look like. They're itchy, they burn, your patient is just generally uncomfortable. This is what I was talking about with my allergy to latex. I could do this. Somebody has taken something that they were allergic to and caused those hives on their skin in the shape of those letters that say skin writing. Here's another good sort of picture of our hives. They just look like raised, red, itchy, uncomfortable welts. But they're only localized. If you look, our hives on this patient start about here and end about there. We don't see any hives down here. We don't see any hives up here on the arm. We have a very, very limited area as to where this patient is experiencing that urticaria, those hives. Our GI symptoms, normally pretty run-of-the-mill. That histamine goes out, all of that acidy, nasty feeling in their belly happens. They'll have some cramping, they may have some pain, some nausea, some vomiting. They just have that acidy kind of indigestion type feeling in their stomach. But remember, these are normally not all lumped together. These are mild, non-systemic reaction patients. For a mild allergic reaction, our treatment is pretty much nothing. A localized reaction requires almost no care from us. No epi, no oxygen. It's all supportive in nature. Give them an ice pack over the welt where that bee stung them. You know, be ready for them to vomit in case they do. We don't have to really start getting into the meat and potatoes with these patients because this is a mild reaction. This is an expected thing to happen when our patient is exposed to something that causes them to have an allergic reaction. Anaphylaxis is different. Anaphylaxis, the first time your patient is exposed to something, it'll cause what is known as an anaphylactoid response. The anaphylactoid response is an absolute mimic of anaphylaxis, except it's the first time this patient has ever had it happen to them. That is the body's loading up for the next time this happens. So if your patient reports the first time they got stung by a bee, they had difficulty breathing, they felt dizzy, they felt like they were going to pass out, be ready for that second bee sting to cause this right here. Anaphylaxis is pretty much all of those things that we just talked about an allergic reaction causing, all at the same time. Anaphylaxis is systemic. It involves multiple / all of the body's systems, and especially the major ones, all at the same time. Histamine gets released around the whole body. Histamine causes all of that vasodilation. And what happens if I make the vasculature in the tank too big?
No blood pressure.
No blood pressure. So there's part of the problem of air goes in and out and blood goes round and round. If my patient who is deathly allergic to bee stings has an anaphylactic reaction every time they're stung by a bee, gets stung by a bee and has all of this wide scale vasodilation, their blood pressure goes in the tank and that blood stops going round and round. Then we add to it respiratory and airway compromise because all of those mucous membranes start to swell and start to leak. Guess what alveoli and all of the lower portions of your airway are lined with? Mucous membranes and mucosal, and they start to swell and they start to leak. And we get bronchoconstriction. So when we listen to our patient's chest, we'll start to hear wheezing, really, really loud wheezing. We may even hear some crackling. And then when we get up into the upper portions of their airway, that's all lined with mucous membranes. And that'll start to swell. And their throat may actually physically close because of the body's response to this allergen. When we see the skin signs, we will see hives. everywhere. They won't just be localized to where that sting happened, to where that bite happened, to where that peanut touched. This is systemic. This is going to be hives everywhere. Your patient now will complain of persistent and worsening abdominal discomfort, uncontrollable nausea, vomiting, diarrhea, abdominal pain that is just ridiculous for no reason. All of that vasodilation is because the body has encountered something bad. The body has encountered something that it wants to try and get rid of. So it wants to try and get more blood to the area to try and get rid of that. But the problem is it has already spread that bad thing everywhere. So the more blood that the body is trying to pump round and round, the more it is spreading this chemical to the far reaches of the body. It is causing more vasodilation. It is causing more leaking of the capillaries, and it is causing more angioedema and swelling of the mucous membranes. This is a legitimate picture. Somebody who's allergic to something and gets that introduced to them will have this kind of angioedema. Their eyes will swell to the point where they're nearly shut. Their lips and their tongue will swell to a point where they don't even look anatomic anymore. This patient couldn't get his tongue back in his mouth if his life depended on it because of all that swelling and all that vasodilation. Some of the other things we'll see is respiratory distress. The airway is going to constrict. The airway is going to swell. We're going to hear wheezing. We're going to hear stridor. Mucus is going to begin to build up. My patient's going to start using all sorts of accessory muscles to breathe. They're going to start to be tachypnic, which means breathing fast. They're going to be tachycardic. But in the effort to get more gas in and speed up the heart rate to move more blood round and round, we still don't have any pressure. And if we don't have any pressure, nothing is going to go anywhere. So what do?
EpiPen.
EpiPen. You're absolutely right. Our treatment for this, our first line drug for this problem is going to be the same as it would be if we were some fancy doctor in an emergency room down in downtown Boston. 0.3 milligrams of epinephrine IM with an auto injector in the lateral aspect of the thigh. We're going to hold it there for between 5 and 10 seconds. And then we're going to remove the EpiPen, throw it in the sharps container, and massage the area, trying to force that medication into our patient's bloodstream faster. And what's that epinephrine going to do? Because it doesn't get rid of the allergen.
Does it help the own system antihistamine release with the adrenaline?
So it doesn't help anything as far as antihistamine goes. What does epinephrine do when it's floating around inside your patient?
It I can't remember if it's like
Opens up the veins.
it
Somebody
opens
said
Dilates them.
Try it again. What does it do to the veins?
it opens up the veins.
Dilates them.
They're already dilated, right?
Can
All
anyone
these
hear me?
chemicals caused the vasodilation. That's why we have no pressure.
Oh, sorry, constricts.
Does anyone hear me?
And it opens up your airways.
It opens up your airways. It reverses all the airway constriction and all the airway swelling by shrinking those mucosal membranes back down. But it closes down the vasculature. It reacts on that smooth muscle in the arteries and clamps everything down to make the pressure go up, and it reverses the hypotension. It reverses the difficulty breathing. It fixes that angioedema. And in very short order, you watch all of these things melt off into nothing. So we already went over all that, the 6 rights and EpiPen administration and all that. So here's a couple of protocol things. Let's have a look at this. We can re-administer a second auto-injector in 5 minutes if need be. If my patient is over the age of 65, I am not going to give him any epinephrine without making a phone call. Why does epinephrine to a patient over the age of 65 require a phone call to the doc?
Can it kill them?
It can, but how?
Possible already like heart issues that they could have, or like other medication that they're on.
Yes, they could already have some of that arteriosclerosis or that atherosclerosis. So product of aging, double cheeseburgers, heart conditions, things that may be affected by the administration of this epinephrine because it's vasoactive and going to clamp down that vasculature. It would really be a lousy day for this patient if I gave my 68-year-old patient an injection of epinephrine and reversed their anaphylaxis and caused them to have a stroke, caused them to have a heart attack. And here's our pediatrics. Our pediatric is a patient over the age of 6 months and under the weight of 25 kilograms or 60 pounds is going to get 0.15 milligrams of epinephrine auto-injector, lateral aspect of the thigh, held for 10 seconds, and then massage the area. The dose is different because kids aren't just little adults. We give them a smaller dose because they're smaller people. And if they're under the age of 6 months, we're going to call medical control because kids under the age of 6 months are generally still protected by mom's immunity. They're also not generally exposed to a whole lot of different foods and things and bee stings and snake bites and all that other foolishness. So it would be weird for them to have a true anaphylactic emergency. And it would bear somebody looking at, is there something else going on here before we give this, 5-month-old patient a medication that is very, very significant. It acts on the blood vessels, it acts on the heart, it acts on the lungs. It is a very potent, very serious, significant medication. So we decide to give epinephrine based on protocol, based on presentation, when our patient has multiple body systems being affected in negative ways at the same time. Our just run-of-the-mill, non-insignificant allergic reaction where my patient had that one little spot on their arm that was itchy or that was swollen or that was raised. Okay, fine, that's uncomfortable, I'm sorry. But now look at the difference. If we're going to make the decision to give epinephrine, we're going to have respiratory compromise, decreased systolic blood pressure, and evidence of end organ hypoperfusion. End organ meaning my patient is flushed because all that vasodilation has forced blood way out into the far reaches. They'll be covered in hives. They will be maybe a little altered, maybe a little afraid, but we're going to have a respiratory problem, a circulatory problem, an airway problem. All of those things go hand in hand with epi administration. And you'll recognize it the very first time you see it, because you'll see that big, swollen, itchy, horrible looking face and hives all over, and a patient who might have a blood pressure of 70 over nothing. And they're tacking away at 140, 150 beats per minute, and their respiratory rate is raging crazy out of control. And you hear all sorts of hives and weird noises in their lungs. And they say, I'm allergic to peanuts. And the look on their face, they know that they need epinephrine. You know that they need epinephrine. And when you get in here to class, we're going to talk about EpiPen auto-injector administration and some of the new stuff we get to do, which is check and inject epinephrine. You'll actually be able to draw up epinephrine from a vial and inject it with a regular needle into your patient and watch them get better. Let me ask you one last question, and then it's time to break for lunch. When would you decide to give a second EpiPen? Because you can. What would make you do it?
After you reassess, you need to reassess your patient every 3 to 5 minutes.
Okay. And what would make you look at the patient and go, boy, I think I probably ought to stick them again?
Like the oxygen's still really low, the blood pressure's still really low. Nothing really improved. Even if it improved a little bit, it's not like what you need, like like better baselines.
Good. You gave the first one, and your patient got better, but didn't get better enough. And now you're starting to see these negative signs and symptoms return. Absolutely, they get to ride the EpiPen train again. Or you gave that first epi, and your patient didn't get better at all because they were so deep in the woods that realistically, they were really, really sick. And all that first epinephrine did was keep them alive. And now 5 minutes later on reassessment, you have refractory anaphylaxis, which means you treated it and it didn't go anywhere. And now it's time to treat it again. So reassessing your patient and following where all of these signs and symptoms leads you is going to be when we can draw the line to, do I medicate this patient again? Because like I said, epinephrine is not a benign medicine. It is not something to be taken lightly. It is absolutely something that will save your patient, but make sure you're following through and giving it to the right people. All right, I got us in town right on